Today, actually, we have an invited talk from Dr. Giannouchos. He's an assistant professor at the Department of Health Policy and Organization, School of Public Health at University of Alabama at Birmingham. He's also a program director of MSPH in Outcomes Research and associate scientist at UAB Centers for Outcomes and Effective Research and Education. So if I were to introduce a little bit, because I'm the host, I asked Dr. Giannouchos to come give a talk so that I can bring in the more outcomes, like outcomes, database studies, secondary database studies from the health side more into the TAMIDS Institute. I think you have people in silos in academic institutions a lot, and we were talking in the car, people in public health or in health sciences that do outcomes research with databases that don't always connect themselves with data science. Although if you go look at the definition of data science, that is the definition, using secondary databases to learn things, answer questions. And so I thought it would be helpful if there was more interaction to introduce some of the more fundamental methodologies that is more commonly accepted in that field into the general language of data science, as well as data science. So that interaction, I think, is really important. And I hadn't seen any of the talks at the TAMIDS Institute that cover that aspect. So that's why I invited the talks.
Yeah, so thank you for hosting, first of all, TAMIDS, the presentation, and Dr. Thum, thanks for inviting me. I'm a graduate of A&M, so I graduated with my PhD in May 2020, and it's been 3.5 years. I'm excited to be back on a rainy day, but still, it's nice memories. So I think Dr. Thum covered the rationale of having me here today presenting what I'm going to present, which is essentially more of the highly accepted and more rigorous methods that we use in the field of public health or health service research / health econ, and combined with large databases that exist in the healthcare sector, trying to answer timely and relevant questions related to, in this case, the health policy arena, and specific. My presentation is structured as 3 main points. The first one is, what are these quasi-experimental methods that we use to evaluate health outcomes or health policies in health service research? What kind of data can we use, and what are claims data? Because although they're, in my opinion, at least one of the most rigorous databases that someone can use, people are not very familiar with it and how they look like and what can be done with those. So I've created some small fake things for you to get a sense of how they look like, and maybe you have other ideas than I have, and how you can use those to answer. In this case, to evaluate what happened before and after a state in the US decided to enact a law where they capped how much patients are paying out of pocket for insulin, so for diabetic patients, which is a very hot topic given that there's a push at the federal level to do that as well. And we're going to see what's happening. What does the first evidence show? Disclosures, I have no conflict of interest, and I would like to acknowledge my 2 collaborators on this project, Dr. Euchert and Dr. Brickmuller. Dr. Euchert is at A&M, and Dr. Brickmuller is at the University of Michigan. So as I said, 3 main pillars today. One is a brief overview of the fundamentals of highly accepted and highly used methods to evaluate health policies, and particularly we're going to focus on difference in difference today, which many people use, but not many people understand. Claims data, what are claims data, how they look like, in particular, because we are in the healthcare sector, we're going to look at health insurance data. And then we're going to tackle the problem of what did that copay cap policy do on insulin outcomes. First of all, a bit of background so that we are on the same page. Why is it important? What we did, how we did it, what we found, and a couple of slides and ideas about what these things mean, future work, what are the limitations of what they did using these methods and these data, and so on. I always like to start my presentation that are related to health policy evaluation with this slide, which essentially shows you any policy life cycle, but also essentially the health policy life cycle here. And we are particularly, as health outcomes researchers in general, focused on the part of once the policy gets implemented, what happened? Did it work? we evaluate the outcomes of the policy, and the goal is then to move to the next question to make suggestions. What do we do with it? Do we maintain it? Do we need to disregard it? Do we need to tweak it? And you're going to see exactly how relevant it is to the insulin problem. So we are here on the fourth step, where we come in the first step of the policy life cycles. In terms of methods to evaluate health policies, I think most of us have heard of, and those who have read a bit more or know a few more things will agree or will accept, I would say, that RCTs or randomized clinical trials, particularly double-blind clinical trials, are the gold standard to evaluate the effect of X on Y, right? The effect of a drug or a new drug on the targeted health outcome, particularly double-blind. However, this is a pure experimental setting. It's also in a controlled clinical setting, ideal situation, ideal scenario, everything is controlled. But in a health policy perspective, or for a public health nationwide or statewide system perspective, it's very hard to do randomized experience, right? And the concerns are either or, I would say both cost related, right? It's very expensive to do it. It's also very expensive to collect the data, right? But it's also unethical, right? They're not unheard of. The biggest kind of RCT experiment in the healthcare in the US, or the run health insurance experiment. For those who are not familiar with it, essentially they assigned insurance to people randomly who didn't have insurance before, and they were following over time to see what happened. But there's always an ethical component, right? If we know that, for example, minimum copays improve treatment adherence, as in this case, then why don't we make it free to everyone if we have the resources, right? So the ethical constraint is equity and all of those things. So in short, we can agree that these are very hard to implement. It doesn't mean, however, that we can't use what we call post-experimental design, so various econometric methods to evaluate what's happening when health policies get implemented using large secondary data. This is the norm. Why? Because the ethic component is gone, the policies have not been implemented for various reasons, and the cost is not there because we're using existing data and data science, econometric statistics, however you want to call those things. However, we have to be very careful because these methods rely on certain assumptions, and we have to meet specific criteria to provide accurate estimates. Because here we are interested to evaluate the effect of X and Y, the impact or cessation of X and Y, and we are focusing on treatment effects or on any effect. So the p-values, the statistical significance, and the magnitude of the effect will shape the policy, right? And if we do it wrong, then we might make wrong recommendations. And wrong recommendations in the health policy arena might harm people down the road. Okay, if the policy improves people's outcomes and we find that they don't, and we're the only evaluator, then we're making a negative suggestion to the policy stakeholder. And because the biggest problem in the healthcare sector, or one of the biggest problems, is that we don't have unlimited resources to pay for everything, we have to ration. So these things, if we show wrongfully with wrong statistics or wrong analysis that the policy doesn't work, then the state, the stakeholder, the federal government, the healthcare system might choose to spend that money elsewhere, right? So we made the suggestion here. So we have to be very careful with the assumptions and the criteria that we have to meet. And as with RCTs, the strongest way to make a claim that something is working is to expose one group, the treatment group, to the policy or to whatever we are evaluating, and then we have a concurrent counterfactual. So a control group that is at the same time didn't get exposed to the treatment, and start comparing those two and see what's happening. Now, before we get there, we have to make the assumption, of course, that we have a control group, and so we have to make the assumption that this is possible. And many times it is not possible, because if there is a large-scale policy at the country level, at the federal level, or in a non-US country, like I'm from Greece, for example, national healthcare system, everyone falls under that umbrella. If they make a policy, it affects everyone, right? So in that case, there's no concurrent control group that's kind of similar, except if you compare it to another country. So there you have validity threats, right? Because the only thing you see is before and after the treatment in the same group. So you might deal with confounding omitted variable bias, which, you know, there are other assumptions in there. It does not mean that it's not important, right? But you have to assume that in a scenario like this, which is a time series approach of California's cigarette law to reduce, where they implemented tax to reduce cigarette sales. Well, they just studied California in this case, right? So you can see that when the policy was implemented in 1889, they had the trend before and after. So in this case here, yeah, there appears to be a drop here, and we agree that it went down. But the big question is, well, it was going down anyway, right? So it was going down anyway. The slope seems to change. Do you attribute that 100% to the policy here or not? Maybe, maybe not, right? And the other assumption is there anything else that happened in 1989 that might have affected this outcome, right? Which we don't see in the data, because you rely completely here on treatment outcome and time, right? So you assume that everything that's happening here is time related. But as you can see, you know, it started dropping anyway. There's a slope change here, but maybe, maybe not, okay? So we are limited in these cases here by the absence of a concurrent control group. So when we include, if we have the ability to include a concurrent control group, it will definitely enhance our confidence in the validity of the findings. And three of the most common methods that are used in the health policy evaluation area in particular that involve treatment and control groups are difference in difference, which is my main focus today. I just want to bring up the two other very commonly used approaches: regressionist continuity designs and matching. And most have the common assumptions, with the biggest one being that there is a control group and a treatment group, and they are similar in everything else except the treatments. So they try to mimic a randomized clinical trial, as I explained. Okay. So today I'm going to talk about difference in difference, and I'm going to go through the assumptions and why those have to be met and how we are trying to meet those, and then the application of it in the policy of interest today. So essentially, as I said before, what we want to know is how much a treatment, if it affects the outcome, and how big that relationship is, that effect is. Which means that first of all, what we look like, as the California graph before, is we look within the treatment, right? What was happening before, we have an intervention, and then we're looking what's happening after. Well, the problem, as we saw with the California example, is that you assume that all the change is happening at the time the policy is implemented. So you assume there's a relationship between treatment and the outcome due to time, right? Because time is your only exposure here. You don't know what's happening on the ground, you just know the time point at this. So you make an assumption, you put in a variable there, and whatever that coefficient is your effect set, right? So you're highly dependent on time. And that is a problem. So how did that whole field, that whole idea of PID happen? I'm just going to give you the nice historical overview with Jon Snow, not the Game of Thrones one, the physician one in the 19th century. So at that time, we have a few clinicians in the room that I met before. People didn't know how diseases were spread. They thought it was spread by air, they called it miasma. And there was a huge cholera outbreak in London, which was spread apparently by water and not by air. And this physician, Jon Snow, actually did the first difference in difference without him knowing that he did it. So what he noticed is that at the time the cholera was spreading, there was a neighborhood in London that actually it went down, the rates went down. And then he started thinking about it, why people who live nearby in the city that is infested with a disease actually are doing better. So he noticed that at some point in that area, in the neighborhood where people were living, what happened is by a parliament act, by essentially a law, the company that was providing water to that area changed. All the companies were taking water upstream, and this company did it downstream, vice versa. So that was the change, right? And he knew that that neighborhood was getting clean water all of a sudden, whereas the others kept getting the dirty water. So he collected his samples, he collected the data, he did some calculations, and then essentially he had a treatment group here, the group that used to get dirty water before, right? And then after the company changed the stream, the rates, the outcomes here, 85. So you can see a drop here in the cholera cases, which is great. But he thought, well, I need a control group because how do I know that this is because of just the company, like in the California example before, right? So he went and collected the same data in neighborhoods where the company didn't change, and he found actually an increase. And if you look at the proportional change, it's actually a big change, right? So this is the premise of difference in difference, right? It's called difference in difference because you have the first difference is here, right? And then the second difference, so the difference of the first difference. So this is the logic of how these things happen. Now we've moved miles beyond that, but this is the brief historical overview. But in general, we can all agree that if we have a concurrent counterfactual or control group, it enhances the validity of our findings, particularly as in his case, one group went up not for no reason or remained steady, and the other group went down, and there's a reason, there's something that's happening in there, right? So, of course, you can't be 100% accurate because it's a real world. It's a real world, not an experimental setting, but it boosts our confidence that it's working. And when we include the untreated group, the control group, the group essentially that never receives treatment, we introduce here another door. Okay, so as you remember before, without the control group, we have the issue of time, right? Because we only assume that time is changing, and it is, but all the effect is because of time variation, and that's a problem. And suddenly, when we decide to include the control group, we get essentially each other cancels out. And how does that happen? It happens in two ways. So we isolate first the within variation for both groups before and after, okay? And then we compare the within variation between groups. So you fix that, and then we fix that as well. So this is the big premise here. And in this way, quasi-experimentally, we can mimic a kind of randomized event. Of course, health policy changes are not random, but they're random to the people who get affected because it's impossible for us to predict what's going to happen in 6 years from a healthcare perspective to change our behaviors or any sort of those things. So we can agree that on the ground, it kind of mimics randomized clinical trials. This is the model, essentially how you can implement. This is the oversimplified version of a model, as I said before, and it's easier for me to show it in the graph. You have a control group and you have a treatment group. You have the policy implementation at some point in time. The control group shouldn't change, right? Whatever your outcome here is, why it was increasing over time, it kept increasing on a steady pace. So this is the ideal scenario, right? Your treatment group was increasing, the treatment happened, it went up, it kept increasing. So the difference in the control group is the before and after, same in the treatment group. But then you have a small difference here, which is essentially the difference. So it's essentially the difference of what should have happened if there was no policy, because if the policy wasn't implemented, it should have kept going as it was going, right? But something happened, they have to change the route of things. And it's that difference that we are trying to explain with this approach. Again, very simple statistics, essentially it's interaction term here between treatment assignment and time in its oversimplified version. But this is the big assumption. When you start implementing event studies, so starting to count the trends, you usually, for the simplified model, you look at the average before and the average after, not just a simple time. So you take into account all the temporal trends and the underlying trends here. However, that was the ideal scenario, right? And usually in the healthcare sector, there is no ideal scenario with real world data and all of those things. Because just including some control group or a well-defined control group doesn't mean that we can infer causality, because certain assumptions have to be met, which I'm going to cover in a bit. But look at this case. You have a treatment and control group before and after. You have a policy, and then this happened, right? So what do you do here? Like this is really hard. Was it the policy? Well, both increased, and actually the control group went up higher. can you infer here that there is any policy change? It's very hard, right? So it doesn't work always in our favor, but there are ways to deal with it, or there are also ideal scenarios like the one that I showed you. But we have to start from the basics, right? And the biggest assumption, if you compare this to and you look at the basic foundation of the idea here, is that in the pre-policy period, if you notice, essentially the treatment and the control group are parallel, right? The trend is similar, is a parallel trend, which means that the differences here are steady. Okay, it matters where they are in terms of the level, but the biggest thing is that they were following similar trends, or what is called parallel trends. And in other words, what we are interested here is to say that if there was no treatment, and that gap, that steady difference would have remained steady over time as well. So that difference is the first difference, the difference essentially. And why are we interested in that? Because if you saw how we calculate the first difference is the difference in the treatment group before and after, the policy and the control group before and after, we make two assumptions here. One is the unobserved assumption that, okay, there could be other changes going on in either group that are unrelated to the policy that might affect the outcome. But the difference in the treatment group, except for the unobserved changes, also has the treatment effect in there, right? So if the trends are parallel and we do the simple maths, you will see that the estimator here, the DD estimator, is essentially the effect of treatment plus the other changes in the treated group minus the other changes in the control group, the unobserved ones. So for us to capture as accurately as possible the treatment effect, the estimate, these two need to be similar, right? So if the trends are parallel, essentially, all the unobserved differences, they cancel each other out. So what remains is the clean, the accurate estimate. Here's another scenario, and I'm just bringing it up for our own sake. Like you can see here that the trends seem to be parallel or are parallel. The intervention happened, observed treatment effect outcome decreased, assuming it's a policy that wants to contain something. But as you can see here in this case, also the observed control group went down. Okay. Based on the assumption we make so far, we would assume that this one shouldn't change, right? It should have remained stable. For some reason, it went down, which means that if you look at that formula before here, these two are not equal anymore, right? So in this case, actually, you get an underestimated effect because actually it's bigger, but because of the change in the control group, what you calculate is smaller. So in this case, you might underestimate the treatment effect. Which in the grand scheme of things, for me as a researcher personally, it's better to underestimate, assuming that you find that it works. If it works, it's better for me to underestimate than to overestimate. But again, both are problematic, right? And this is a scenario where you underestimate the treatment. Now, how to pick, because all of those things essentially rely on having a good control group, right? The control group here takes care of unobserved things, and usually three big things that we have to have in mind. One is that there's no particular reason why there should be a change in the control group after the policy implementation period, because it never got affected by the policy. And essentially how we can look into that, we can use multiple time points in the pre-treatment period. The second thing that we have in mind is that if we make sure that the treatment, like in RCTs, right, the treatment and control groups are as similar as possible in observables, then we are pretty much comparing similar groups. The main thing is that they were exposed to the thing differently. And the third big assumption is we look at the trends before and make sure that we're parallel, we're very similar. Essentially, there's no direct way to control for parallel trends, because we assume that the control group is this one just because it had parallel trends, and we assume that there shouldn't be any change. But at least if we capture that, then it makes our assumptions and our findings more credible and more valid. And essentially, one way to indirectly test for parallel trends is you implement the same DID model, but instead of interacting the treatment variable, You use time indicators for the pre-policy period, and then you interact with the treatment dummy, and then you get variation in pre-policy trend. And I'm going to show you in our paper how it looks like. So again, here, if this estimator here is insignificant throughout all interactions, then essentially that gives you a sense that the trends are parallel. Another way is you can use placebo tests. You just pick random periods in the pre-treatment period, and you pretend that, okay, something happened in that period, which it didn't, but if you consistently find insignificant the estimators here, then there's no noise. There's nothing going on there to bias your conclusions. And this is a very general overview, just so that we are all, we have the basic of these methods. I just want to bring some things up because this is recorded and posted online, so I don't want to be on the hook here. The things I presented so far here, essentially we're calculating the average treatment effect because we're dealing with two periods, pre-post between two groups. So we're dealing with a post period as one period. It doesn't matter if we have 10 years. This estimator is going to give you one coefficient and it's average treatment effect. But we have to take into account that many policies are dynamic, right? They might not do anything in the first year because people need to get used to something, or people don't know it. And then in the second year, some people start getting affected by it. And then in the third year, more people. In the fourth year, more people, and so on. And you can do that. You just change your variables. That's called dynamic treatment effect. So you can then calculate the treatment effect over time, how it's evolving. New methods in DD is we can have multiple groups that get affected, and multiple groups also getting affected over multiple treatment groups. The classic example in the healthcare sector is Medicaid expansion, right? Some states never expanded, some states expanded in 14, some in 15, some in 16, some in 18. They're still expanding, right? So there, the treatment is not a dummy anymore because you have different things affecting different groups as well. And the big idea here is that the models are good as good the control group is, because the control group boosts our confidence. Alternative approaches, if like in that example I showed, there is no control group that meets the pre-specified criteria that we want, you can match. You can use like some sort of matching method, or you can just create synthetic control groups through weighting. So you have one or a bunch of control groups, none of them is good. You can combine them, assign weights to make them meet those assumptions. And there's a lot of code out there for those who are interested to look at how that works. So there are ways around it, but the big premise here is we have to be careful about the time trends between the groups and what is going on. I hope we're just all on the same page about DD and how we use it in general in the healthcare sector. Now, to use this kind of methods, I said in the beginning that we have the issue of time, right? Time is everywhere, right? So you need to use a data set where essentially you have panel data or observations where the unit of analysis is something with time, right? State year, for example, in the case of medical expansion. Or insured people, something like that. You need something where the unit of analysis is the month, the year, the day, the week, right? And these are called panel data, right? There are many existing databases, secondary databases, and some are even publicly available where people do good work with it to retrospectively use to evaluate health policies and health policy related outcomes. And mostly, and we'll agree, it depends on the question you ask, right? It depends on what your outcome is, what the policy you're looking into is, and what you want to do as a researcher. For example, the work that Com and I have done has looked into Medicaid expansion at ED visits, which means that you have to have ED data for states that expanded Medicaid, your treatment group, before and after the expansion, ED data for states that did not expand Medicaid, which is your control group, and they need to be for a good amount of time before and after, let's say 2014, for example. And in our case, the unit of analysis here could be the state, or it could be counties within states, aggregate visits over time. Okay? But keep in mind that now you have a bunch of assumptions that you have to meet here, right? First one is it a good control group, the groups that you have? Do you have parallel trends? And then are they similar? And did something happen in either the treatment or the control group around the time of the treatment of the policy implementation that might have affected ED visits in this case in a way that your model is not capturing? For example, if a state expanded Medicaid and all the states won the lottery, then right, ED visits could have been affected, but it wouldn't be related to Medicaid, right? It could be something else. So this is an example. Another example would be, again, looking at Medicaid expansion, for example, and self-reported health. People have done this work, assuming that, if we give more people insurance coverage, then people are going to be safer, healthier, going to have access to healthcare. So they should feel better, so their health status should improve, right? That's a completely different problem because you need to ask people, what do you think your healthcare status is, right? And now here you need patient level, individual level data. You need to ask people who live in states that expand Medicaid how they feel before and after the expansion. And the same in non-expansion states. And you need to do it in years before and after the expansion. Now you can do it at the state level. You aggregate self-reported outcomes with frequencies, for example, proportion of people who report excellent health status and follow that over time, or at the county level, or you can do patient panels still at the patient levels. Again, assumptions here, a lot of assumptions, but it can be very difficult when you have questions that force you, or where you have to follow the same individual over time, because then you introduce selection bias and all of those things if your panels are not balanced over time. You keep asking different people, so you have all sorts of issues in there. And the other thing is, we really don't know when a policy gets implemented. How, if I want to study Medicaid expansion, for example, how it affects ED visits, or not ED visits, I would say like self-reported health. I don't know. I would know in 2008 if my state would expand Medicaid in 2014 to start collecting balanced panel data from 2008. No, it's impossible. Like, these things are dynamic. It's a dynamic arena, so we have to be flexible and be aware of the resources that are out there and how those can be used to answer in a timely manner, in an accurate manner, in a useful manner, health policy questions of interest. But again, remember the assumptions for a period of time. Patient level claims data are among the strongest databases one can use. I know that not many people have used healthcare claims data or are not familiar with those, so I thought it was very useful, since this data science topic one, to just show you how those look like and for you to understand how to use them. But once you understand how to use them, it will become apparent how strong this data are. So essentially, what are patient level claims data? Everything that the health provider, any healthcare provider, bills an insurance company. So if you go to the doctor, there's a bill, right? Your doctor bills your insurance, assuming that you're insured, right? He bills your insurer to get reimbursed for whatever he did to you, okay? Or whatever you needed. That's in the data. Or then you went to the pharmacy and you took your pills. That's in the data. So practically, many states have those. They're called all-payer claims. Medicaid has it at the national level, and Medicare has it as well, both at the sample and national. A lot of them, particularly with the federal agencies. Medicare is 50% of the US population, and you have data for everyone, what they do in the healthcare spectrum across the continuum. So you can see people over time. Now, these data have identifiers, encrypted identifiers, so you can track how people use healthcare services over time, and these are already collected for you. Now, you can't answer every question, but if you're interested in utilization and outcomes and those things, there are many, many things that you can do with this data, because these are already out there. They can be expensive. They require Herculean efforts to quote them, because we are talking about billions of claims. but there they are. You know? They usually have medical and pharmaceutical history data. By medical is hospital, ED, outpatient, anything. Pharma history, so whatever drugs you take, they're in there. And they usually come with files that show the insurance enrollment status. And that's really critical. And I'm just going to show you, that's a piece that I've encountered people missing sometimes. I think it's important to bring up why this is important. This is, for example, a fake data set of a claims database for medical services. You can see here there's a patient ID. For example, here is patient 1. And you see oversimplified. Okay, there are hundreds of variables in these data sets, but I'll just give you a sense of how this works. You see the date of the encounter, so you know when the patient did what. In this case, you see what type of visit it was, outpatient, ED, inpatient, etc. You can have an ICD code, why this happened, okay, what happened. The length of stay, if it was an admission. You usually see how much the patient paid out of pocket. You see how much the insurer plan paid out of to the provider for this service. And you also, one of the things that you see that might be of importance if they were discharged alive or dead, okay? So again, oversimplified, usually it's very dirtier than that. You hope to end up here to understand it. But if you end up here, this is something that you might be looking at. The pharmaceutical claims data, again, this is the same person. You see the dates. NDC is what's called National Drug Code. So every product has a code. So for example, this might be an insulin or this might be ibuprofen. You can find those, you can download those codes, they're available online. So essentially now you know this patient on that day took this drug, the supply that the prescription lasted for 90 days. So the quantity he had in his hands should be enough. For 90 days, he paid 182, the insurer paid 1,600, and status usually comes with it was approved because sometimes there are reconciliation claims or you see negative numbers here, they billed wrong, you know, stuff like that. So these are considerations for the future, but this is then what the claims database for pharmaceuticals would look like. And then, oops, they usually get a file about enrollment status, and this should be really careful with this because you see again, you have an ID, this person, this comes usually at the month level. So you can see this person was insured in January, February, March, like continuously. And you usually have the type of insurance, in this case, it's employer sponsored, high deductible health plan, active, so the plan is still active, right? Age, sex, zip code. And what you see many times with health insurance is when people change jobs, for example, they change insurance, right? Or when people turn 65, they go into Medicare, right? So, or people lose their job and they go uninsured for many periods of time. They're uninsured for 3 months, and then from April it shows up again next year, right? Or someone loses their job, doesn't have a job, and they're eligible to go to Medicaid, okay? So you see those switches all the time. So depending again on your question, as you're going to see in my question today, for me it was very important to only study people who are continuously enrolled in the same health plan, because if you study an outcome that is related to utilization, today in my case on treatment and medication adherence, if someone loses insurance and can't pay for the drugs anymore, and it's not that the policy was bad, it's like those people weren't adherent anymore because they lost insurance and they couldn't pay for it. Okay, so you have to be, again, assumptions, different kind of assumptions at a different level, but this is something that you need to be very careful with, how to handle the enrollment status data. So I'm just going to briefly show you today what I'm working on with my two co-authors. We are looking at the state level insulin copay policy and what happened in outcomes. Why we're studying diabetes, for ease of time, I'm going to be very quick. It's the most expensive chronic condition in the US. 1 in 10 people have diabetes, 1 in 3 have pre-diabetes. Around 15% of those with diabetes are on insulin. Insulin is very expensive in the US. Diabetes and diabetes-related outcomes account for 1 in every 4 healthcare dollars spent in the US. So we can agree that it's a serious chronic condition that affects many people. will affect more people over time, expensive to treat. More than 7 million people use insulin. Insulin products are very expensive. They're around $100 per vial, not per pack. So we're talking about in the thousands per prescription. Costs for insulin have tripled over the past decade. Some products even increased almost 600% and up. So naturally, at the patient level, it creates severe affordability. Okay, so people rely on insulin, increased costs, increased out-of-pocket payments. That's a problem. It's estimated that individuals with diabetes spend $60 to $70 per prescription out of pocket. But people, for example, with type 1 diabetes, they use 2 types of insulin, and they also need needles and other stuff. So we're talking about a huge amount. And people also develop diabetes later in life, where they have a bunch of other chronic conditions. So we're talking about polypharmacy here, multiple medical encounters. And just to give you the numbers here, about 40% about 50% of insulin users reach catastrophic spending. So they allocate almost half of their income on insulin-related treatment stuff. And a same proportion, 1 in 6, 1 in 7 insulin users report consistently over the past decade that they skip or ration doses because of cost. That's called cost-related non-adherence to treatment. So the assumption here is that if you decrease costs, that barrier goes away, so adherence should go up, right? And there is tons of research that has shown this, that there's an inverse relationship between copays, adherence. So if copays go down, adherence goes up, and if adherence goes up, people are healthier, they have better outcomes, less complications, less use of more intensive healthcare services, and that's a good thing, right? Everyone benefits. So to date, starting 2020, 25 states and the District of Columbia have imposed state-level copay caps on out-of-pocket spending for insulins. So did CMS for Medicare in 2022. The first state was Colorado, January 2020. I think Texas did it last year, a couple of years. So there's a lot happening here, particularly with the numbers that I showed you before. And the only evidence we have so far in the literature is a preliminary study looking at the IRA on Medicare release, which, given that we all know that data lag, so they only had data 4 years post-policy implementation of Medicare's copay cap, and they found for now that fills increased, and the share of fills for those below the $35 copay cap that Medicare implemented went up. Straightforward, right? And that's all we know. We don't know anything about outcomes so far now. So there's no study looking into those things, and this is the first study we are doing, and what I'm going to present very briefly. We evaluate how a state-level copay cap policy was associated with out-of-pocket spending for prescriptions, treatment adherence, and healthcare utilization for short-term related complications. As I set the ground, we studied Colorado. Why? Because Colorado was the first state that did it in January 2020. And with data lagging, now we have a good amount of post-policy data to have enough trends and things like that. It was effective January 1st, 2020. The state of Colorado capped insulin copays at $100 per prescription for the 30-day supply. The first state that did it. And another important strength of Colorado is they have an all-payer. Okay, they do have a database. 40 commercial payers, Medicare, Medicaid as well. 5.5 million lives, more than 1 billion claims in the database, and they have medical, pharmaceutical, and enrollment. Essentially, the 3 things that I presented today. We used 1 year before at the month level, so we had 12 time points before and 12 times after. Why? Because we had at that point data to 2020. Now we have more data, and we keep working on this. And we studied type 1 diabetics. Why type 1 diabetics? Because type 1 diabetics have to use insulin, both usually 2 types of insulin usually. So if you want to study a policy that affects insulins, you have to study people who use it regularly, and most type 2 use it as well, but they're in and out, like they switch to oral agents and stuff like that. We study people of 18 to 64 because at 65 you get Medicare and it's a state law. We need people to be continuously enrolled in the same health plan. So active insurance, no gaps. Why? Because if we study treatment adherence, you need to see how people fill prescriptions over time, right? So if there are breaks and people are no longer in the database, then you don't know if they filled a prescription or not, right? So if you have gaps, it's a problem. Of course, we didn't want them to die over the study period. And how do we identify those people? We said we looked into ICD codes and in the medical data file, NDC codes for insulin. In the pharma file, and we said we need to see at least one claim for type 1 medical and at least one claim for both types of insulins 6 months before you can enter the panel. Except for the theory, the statistical theory, the data theory, we have to be practical and also know things about the policy we're evaluating, right? In this case, we are looking at a state level policy. The state level policy affects people with commercial insurance. But the trick here is, because I'm pretty sure that most of you now start thinking, okay, what's your control group, like what's going on here? State laws don't affect actually people who have enrolled in self-insured plans. So if your employer is self-insured, you're covered under the ERISA and you play by federal law. You're not subject to the state. Okay, so you have a law in the state that affects people with commercial insurance, but not everyone with commercial insurance. Okay, so people who are under ERISA plans or self-insured, and that's the majority of plans, are exempt from the state law. So there's no copay. Again, why Colorado? Because there was a variable in the data set where you could see what plan was self-insured or not. So you can distinguish the treatment of the control group. So we had this natural experiment because I think most of us will agree or hope that people won't choose the employer conditional on the insulin copay. Okay, particularly because you can predict that over time. Usually we see the opposite in healthcare, job lock, people not changing the insurer because the job because of insurance. And so we don't think that we have any sort of selection issue in the genetic by people switching insurers because the policy is going to kick in. So we have a treatment group, people in state regulated plans affected by the law, and a control group, people in self-insured plans who are not affected by the state law. Outcomes, as I said, at the month level, out-of-pocket spending, treatment adherence, proportion of days covered. And we looked at short-term diabetes-related complications, particularly hyperglycemia, because we had 1 year of post-policy data, and retinopathy and blindness and all of those conditions will probably manifest, they need years to manifest. So at this point, we look at anything that is induced by improper use of insulin. In this case, we look at how people use services for hyperglycemia in the post-policy period. Was experimental design, difference, as you could realize, we control for patient and plan level covariates. So any difference that exists, we control for them. And we look at the 3 main assumptions, the pre-policy parallel trends. We had parallel trends, and I'm going to show you the graph. One thing that we control for and did the robustness check is what's called anticipation, because people might change their behavior right before the policy. So for example, I might skip the doses in December because the policy is kicking in January. And if I'm paying too much, then I can or skip or ration doses, contain costs. So to deal with that, we also did a robustness check. We excluded 2 months before and 2 months after the policy. So we move away from that. We also compared at least the outcomes between the periods, the pre-period to be, if they're the same. And we had more than 2 million data points, around 1,600 patients with type 1 diabetes, around 3,800 observations. At the baseline month, so when you entered the sample, the panel, similar sociodemographics and comorbidities, and we didn't observe any differences between the outcome, the 3 outcomes in the treatment and the control group for both types of insulins, okay? So out-of-pocket spending was on average 67 per patient per month for basal insulin and 88 for bolus. Adherence was around 64-70% for either in both groups, and completely healthcare use was about 24% per patient per month. And you can see here now the raw numbers. You will see here that they are relatively similar with the p-values. Not a lot of things. These are the pre-policy parallel trends across all outcomes. The dark line here is 0, which is essentially no difference between each month. So these are event study, so we compare each month in all outcomes with each other, and you can see that almost everywhere the confidence intervals are above and below 0, which means that we don't have almost any difference anywhere. So we are confident that whatever we're finding, it's policy related. This is the DID, and essentially we have the 3 outcomes here: out-of-pocket cost, treatment adherence, and the claims. 2 types of insulin for cost and 2 types of insulin for adherence. For claims, we only have 1 because it's everything, right? Treatment and control group, and essentially the difference here will show you that, as you would expect, the cost went down because it was a policy that affected cost. Adherence increased by around 3 percentage points, and complications went slightly down, but not statistically significant. And also here, it's on the verge of being statistically significant. But in general, it seems to work. Costs went down. It's around 20%, the proportional decrease, and this is also around 5-7%. And this is insignificant. It seems to work. We have 1 year of data. Maybe we need more time, but it seems to do something. Now, the big question is, do you think we're done? What is the problem here? So Colorado had a $100 copay cap policy per person per month. That's what Colorado did. It said, we cap it at $100 a month. And these are the outcomes. So what is the problem here? What is the $1 million question from a pure health policy standpoint? Well, the $1 million question here is, who was paying more than $100 before? Because as I showed you, the average out-of-pocket spending is 60 to 70. And they put a policy that, yes, affected those people, but well, if I was paying $20 and the policy is 100, even if I'm subject to the policy, I'm sitting in the treatment group, but I'm never affected, right? So these are underestimations. So then what we did is we found people who spend more than 100 in the pre-policy period in the treatment group, and it was actually 1 in 4. So only 1 in 4 in the treatment group should actually be in the treatment group because all the other ones were spending less, right? So then when we did the analysis, and you can tell them, well, we compared the high spenders versus the low spenders, you can see now there are differences here, striking differences. Adherence in the high spending group, the true affected group, increased by 11 and 14 percentage points, whereas in the low spending group, nothing, right? And in our overall estimates, you couldn't find that. It was hidden, right? It was underestimated. High spenders, short-term complications decrease significant, and it's like 30% decline. The other group, non-affected, nothing. So when we had those 2 combined, we're getting underestimated because it was not clear. Yeah, so essentially the implication of this work is, yes, the policy works, at least for what we're seeing right now. However, all your estimates, all the good things that are happening are concentrated only among the subgroup that's truly affected by the policy. So yes, it's effective, but the success depends on what the level of the cap is, right? And the implications here are multifold because states have implemented caps ranging from 25 to 100. So depending on where the cap is, and depending also on the income of people, the things here are, there are implications. And in our future work, we want to use more data because the real cost saving is going to come from the more rare and serious complications. We want to monitor that. And we want to move away from Colorado to work with Texas data, or Alabama data. And in terms of limitations, which I need to mention, one state, right? How generalizable is this? Short-term follow-up period. Confounding is still possible. You can never get rid of that. And we know that we have underestimation because we were in a scenario of spillover. So the control group had some declines here, for example, which it shouldn't. So we want to start working on maybe a synthetic control group. And yeah, thank you for having me. And please, any questions?